Good morning. This is Sarah with the Department of Medicaid. It's not quite 9:30 and we're still clearing out the waiting room, so we'll give it just a few more minutes before we get started. Good morning. It is 9:30 and the waiting room is about cleared. I see a few more members hopping in. Dr. Schuster, did you sneak in under a different name this morning? Okay, she might not be on with us yet. Good morning. There you are, Dr. Schuster.
Yes, I'm traveling incognito. I'm changing my name here. I guess everybody knows who I am, but there we go. All right.
The waiting room is cleared if you would like to begin.
Okay, thank you. Apologize for being late. I had trouble getting the Zoom to work and I got nervous. But anyway, good morning. We'll call the meeting to order of the Medicaid Advisory Council for May 23rd. And Mackenzie Wallace is not going to be with us today. So Aaron or Kelly, could you do the roll call, please?
Here we go. Can you hear me? Sorry about that.
Yes.
Okay. So Beth, Nina, Susan,
I'm here.
Jerry,
Here.
Heather,
Here.
Garth,
Here.
Steve,
Here.
John. Either John. Okay. Hashma,
Here.
Catherine,
Here.
Barry? Kent?
Kent can't be here. He had an
Oh.
emergency. He texted me this morning.
And Anissa? Sheila is here. Brian? Peggy? And Eric.
We may not have a quorum yet, do we?
You do not. I will
Okay.
keep an eye out for anyone who joins. Sometimes Peggy joins us a few minutes late. I'll let you know.
All right. And I talked to Eric yesterday, so I know that he's gonna be on.
Beth is joining us now.
Okay, great.
And I am here.
Ah, great. Okay. Are we at a quorum now?
No, ma'am.
Okay. All right, so we will skip the approval of the minutes of our last meeting and go on to old business. And the perennial question that we ask is, what is the status of Anthem MCO?
And that is still pending litigation, so there is no update.
We should just record this maybe, Commissioner Lee. I had an other category because I was trying to figure out some follow-up from the language access, and we do have a suggestion I'd like to run by you, Commissioner Lee.
Okay.
And that is that we've had presentations by the MCOs, each one individually, to a number of the TACs, and we've made those available to the MAC members. But the question that I'm hearing from a number of the MAC members, but also in the TAC meetings, is how can we easily and quickly get a translator on the phone when I have a patient in my exam room and realize that we need an interpreter? What they're requesting actually is an easy to follow table, a one pager that would have that information from each of the MCOs on one sheet. Is that something that's doable?
Yeah, I think that's I do think that's a reasonable request. I believe that, so we'll take that back and make sure that we get the appropriate information, because if it's, we don't, I would think that it would be easier to have one language line rather than utilizing 6 different options depending on who the individual is enrolled with. So let us take that back and see what we can get and get that to you.
That would be great. And I'm guessing, I'm no longer in clinical practice, but I'm guessing that if there were a single line, that would be so much easier. I don't know how that would work. And the MCOs have each have lines available or have that service available. But I think for the practitioner, Commissioner, they may know that someone, speaks a different language, but they may, or they may not know that until they get into the exam room if it's a new patient. And so it's that, kind of immediacy that we need. So that would be great. We would appreciate that very much.
Okay, yes, we'll definitely take that back and get something to you. And we can also check on with other states and how that is, how that's operated in other states.
All right, that would be fantastic. I think you would have universal gratitude from all of your providers if we could ease that. And I think it would be certainly in the patient's best interest, the member's best interest too. So thank you very much. We're off to a great start here. So we threw a couple of kind of biggies at you this morning. One is, and I've shared this with the MAC, but many of the people that are on the meeting may not be aware that CMS is sending out new guidance on how MACs and TACs should operate, and also the creation of beneficiary advisory councils. So this looks to me, and this is a 2025 goal of theirs, as I understand. So this looks to me like something that we will need to be working closely with you all from the MAC perspective and the TAC perspective. So I'm gonna toss that big ball over in your court.
Yeah.
And let you go with it.
So, the Centers for Medicare and Medicaid Services, CMS, did drop some final rules. We are still digesting all of those rules. There is a lot of information in there, a lot of things that we have to come into compliance with in various timeframes. But as far as the Medicaid Advisory Committee is concerned, they have stated that all states have to establish a Medicaid Advisory Committee and a beneficiary advisory council, which, MAC and BAC, by July 9th of 2025. And eventually this is where we're going to need a little bit more guidance. Eventually, representation of the BAC transitions over into the MAC. So by, again, a lot of information, but by, so on July 9th of 2025, we have to have our Medicaid Advisory Committee and our BAC established. And this Medicaid Advisory Council is in statute. So we do believe we're going to have to change based on the new federal guidelines. We are going to have to change our statute that covers the MAC. We're going to have to change that up. And so the percentage of the BAC members that are transitioned over onto the MAC or representation on the MAC, for example, it has to be 10% by July 9th of 2025, then 20% by July 9th of 2026, and 25% have to cross over July 26 and on into 27. And so the CMS has also said they will provide some 50% administrative match, which we get that right now anyway for some of our Medicaid Advisory Council meetings. Let's see, what else is it? So currently, in statute, the MAC members are appointed by the governor and other bodies, but the federal rule states that the director of the single state agency of the Medicaid program has to select the members for the MAC and the BAC. So again, that's where we'll have to change that state statute. They also state that the terms has to be the terms of their of the members will be set by the state, and that terms may not be followed immediately by a consecutive term of the same member. So there has to be rotation. They want to ensure that members are rotated regularly and provide, give that fresh perspective. They also are pretty prescriptive about the topics, categories that the BAC and the MACs will discuss. For example, it includes pediatric care, behavioral health care, or I'm sorry, this is the representation, is someone from pediatric care, behavioral health, reproductive health services, services specifically pertaining to individuals over age 65, health services pertaining to individuals with disability, and also having, a member of either a managed care organization or the association that represents the managed care organization. So we would think that would be the Kentucky Association of Health Plans, would also be on the MAC. They also state that we shall include other state agencies serving Medicaid members. So that would be our Department for Community-Based Services, Behavioral Health, DAIL, but those individuals are not voting members. So we will have to have, some of our sister agencies in there, and they do clarify that the topics and the role of the BAC is to advise the state regarding their experience with the Medicaid program on matters of concern related to policy development and matters related to effective administration of the Medicaid program. So still a lot to learn and to digest. Again, they talk about topics for consideration of the meetings, include addition and changes to services, coordination of care, quality of services, eligibility, enrollment, and renewal processes, and beneficiary and provider communications by that state agency and MCOs. Also, they state that the state agency should, help prep members for meaningful contribution. And that at least one state agency executive staff member shall attend all MAC and BAC meetings. So I think we're pretty good. I think we've got, our MAC is almost aligned with some of these measures. We're going to have to do a little bit of tweaking, but again, we have, I think, a good structure, and we need to, continue to dig in and get a little bit more guidance from CMS about the transition of those BAC members over into the MAC. And I think Dr. Parton had her hand up, and then Dr. Bobrowski.
Dr. Bobrowski. Yeah, Beth?
Hey, you're on mute, Beth.
Can you hear us, Beth? Yeah, we can't hear you. We're not getting any sound. No, we're still not. Do you want to put your question in the chat? Because we're not getting any sound from you. Put your question in the chat, and then you may want to turn off your computer and log back on. Let me go to Garth for a question while you're doing that, Beth. Thank you. Garth?
Okay, question, and I may have misheard you or maybe didn't hear you. I didn't hear you mention dental and some of the other TAC representation on our MAC but is this, I know you said we were close to having our MAC matched this new entity, but is our MAC as it is now, is that different than the other Medicaid advisory committee? I may have missed what you said.
So, we will have dental representation, Dr. Bobrowski. Thank you for bringing that up. We do have, we're almost aligned. We're just, the main thing we're going to have to focus on is definitely our members, the membership, so that we have beneficiaries more widely represented on our MAC. And so there's the final rules have, they call for a beneficiary advisory council, which is a BAC, and then a Medicaid advisory council. And those individuals on that BAC will eventually transition over to the MAC to make up 25% of the members. So 25% of the members and on the MAC will have to be beneficiaries or individuals who have who live with a beneficiary, who take care of a beneficiary in some way related to or in the life of that beneficiary, so that they know how the Medicaid program impacts that individual's life, so that they can have input into the program.
Okay, thank you.
And Beth's question, Commissioner, is that she didn't hear any mention about the tax.
Yeah.
And does the new guidance touch on the tax as well?
No, it does not touch on the tax, and that is, is something that is that we can continue. I mean, with the tax the way they are, but I think it does provide us an opportunity to look at the tax and the MAC and see, what sort of efficiencies we can provide. I know that several of the tax right now are focusing on the same topic, for example, so there's some duplication. So I think that that's of the MAC, that newly formed MAC should have some input and some guidance on the way the tax are formed and how they operate. We do want to work with some individuals and get some recommendations, as we go forward on how to best implement all of this stuff. Again, July 2025 is coming right up on us, so we've got a little bit of a work to do to get everything lined out before. And if we have to change statute, that's going to have to be done January, February, when the legislators are in town. So that's something we really need to be thinking about.
Well, and that's a short session coming up, so we know that things have to move quickly. So we really do need to be on top of that. and all of those tax are also set in statute.
Mhm.
So if there's gonna be some changes so just to be clear, the makeup of the BAC, the Beneficiary Advisory Council is 100% members are people that are caretakers for members, essentially.
They could either be members themselves or individuals who take care of individuals who are on Medicaid.
Right.
And so, you know, because there is a concern that it's a little bit difficult sometimes to try to find members to serve, but knowing that we can pay for their for transportation and lodging if we have in-person meetings, for example. We also have to make it an option. For example, there's a requirement in one section of the rule that says that there's a requirement for states to, we have to publicly post the MAC and BAC bylaws, governance structures. And in the final rule, CMS does clarify that BAC members must have the option to include their name on the membership list and publicly posted minutes. So for example, if we do have members and they don't want their names published, then they have that option not to publish their names.
And does it say anything about what the size of the BAC should be?
No,
Would it
I
be a
don't.
minimum of 10 members or 20 members, or is there anything?
No, I haven't
size?
seen that yet. Again, still looking and
Okay.
evaluating. So we've got a lot of work to do by July, and that's just one little section of the final rules. There are other requirements related to access to care, to HCBS, documentation of access to care and service payments, in lieu of services, state directed payments, quality assessment and performance improvements, managed care quality rating systems. So there's a lot in these final rules that we haven't digested yet. I've got a summary of the rules, and the summary itself is over 100 pages. So
Wow.
lots of information in those new rules.
Yeah. So there's a question in the chat, Commissioner, about when would you be taking applications for a person or caregivers to be on the MAC? And how many do you have as of today?
And
Go ahead.
I was just going to say, I really wouldn't even hazard a guess yet until we digest all of the information. Going back to your original question, Dr. Schuster, about, how many, how big is the BAC supposed to be? And currently we do have, Peggy Roark is our member services representative that's on there right now. And as far as on our tax, I don't think that, I'm not sure if we have any representation on those tax of our members.
We do on the behavioral health tax. We have a designated spot for a consumer, and Valerie Mudd has filled that position. We actually have several of us on the MAC that are representing populations of members. Eric Wright is one, I'm one, Kent Gilbert is one, and Mackenzie Wallace are all, appointed to represent persons with disabilities or, the elderly or parts of the population of Medicaid.
Yeah, and I think that the final rule pretty clear is it has to be, actual
Has
members
to be an actual member.
or
Yeah.
caregivers. So, just again, a lot in there. And once we get a little bit more guidance from CMS, we'll know how best to move forward. And we hope that guidance will come pretty soon, because the other thing that we're concerned about is there's a lot of reporting that we have to do. And we've asked, when I say we, the Medicaid directors and particularly the National Association of Medicaid Directors Board have asked CMS for templates so that we can have those reporting requirements sooner rather than later, because there is a lot. One of the things that as I read through the summaries, is all of the reporting we have to do, and not just on, you know, like our MAC meetings. We have to do an annual report, which is fine. We have, you know, our minutes, and we can do those annual reports rather quickly, I think. But there's a lot of reporting requirements for rates. For example, we have to publish every one of our fee schedules online, which we do that anyway, but there's a few other requirements for us related to reporting, lots of reporting requirements around our HCBS services. Some information specific to wait list and how we are handling wait lists that has to be reported to CMS. So lots of stuff in there. I think
Yeah.
Dr. Wright's had his hand up for a minute.
Oh, yeah, Eric?
Yeah, just, yeah, I was kind of curious, the 25% with what is kind of being defined or what we know at this point, what is our current percentage of representation by caregivers or members on the TAC at this point? Do we have a percentage currently?
I don't know the percentage. I know Dr. Schuster had just referenced, you know, some of the individuals that are on there
Okay.
that represent, but I'm not sure of the exact percentage.
Commissioner, this is Erin. I don't have a percentage, but there are several TACs that do have members themselves or their representatives, caretakers. I can pull a number together of how many we have as a whole if you'd like, and send it out to the MAC. I believe the Consumer Rights, IDD, behavioral health. So there are several TACs that do have persons returning that have members and their representatives or caregivers. So I can pull that together if you'd like.
Yes, that would be very helpful. Thank you,
I think
Erin.
that would be very helpful. Erin, thank you.
Of course, I need to to read the final rule to get more questions, right? You know, like I said, the summary is well over 100 pages long, but you know, there's that transition. You have to create a MAC and a BAC, but then there's that transition of members from the BAC to the MAC. So I don't understand, you know, I'm still a little fuzzy about how all that will work when we start transitioning members over from the BAC to the MAC. So
Yeah, it just sounds logistically like you'd have to start with your MAC membership having some percentage of consumers on it. Or else
Yes.
you're going to keep growing the MAC, and they're talking
Yeah.
about term limits and not consecutive terms. So I would guess you would set it up so that people would serve a term and then rotate off, and other people would come on from the MAC,
Mhm.
although you have to grow that percentage, I guess, from 10% to 25%. So lots to be done. Let's keep this on our agenda for
Definitely.
our going forward, and let's keep communicating, Commissioner, about you know, particularly on things that are going to have to be changed in legislation. I think that's going to be a huge lift, just because of the new session will be upon
Mhm.
us. And
Yes.
given that it's a short session and we've got to get it done by then to meet the CMS requirement.
Yeah, so we'll have to start working on legislation now. I mean,
Yeah.
as soon as we can get those sections and parsing out that work for all of the new rules to figure out exactly what all we'll have to do. But the MAC and TAC, you know, we definitely know we have work to do there.
Yeah. Any other questions of Commissioner on this? Did you all have any idea that this was coming, Commissioner, from CMS?
Yeah, a little bit. They had been talking about it for a while. And I guess with my position on the board, I have served on the National Association of Medicaid Directors, you know, in some capacity. I was their finance chair before being elected president this year. So the NAMID board did have some insight into some of the things that were coming down, because CMS does have and the NAMID board has a really good working relationship. And some of these things are, before they're put into rules, they are floated by the board members to see, you know, if this is something that they think would be well received. And you know, some other states don't have the structure that we have here in Kentucky, and they're lacking in their MACs, and, you know, some of them have legislators on their MAC, for example, and some don't even meet. And so I think CMS really wants to make sure that there is outside input into the Medicaid program related to policies and, you know, recommendations. So I think that, you know, that our MAC was really held up as an example of how it can work really well.
And you're in a prime position to hear from other states how they're going about this. So that's going to be incredibly helpful, I would guess.
Yeah.
In
And-
the role as president of the National Association. So that's going to be very important. Well, the MAC stands ready to work with you, certainly in any way that we can, Commissioner. Beth, do you have another question, or your hand is still up? Oh, we still can't hear you. I put an answer to your question in the chat. The tax will continue and they are not touched on in the new rule by CMS. Okay. All right. We'll go on to the next, which is, can you give us kind of an overview of the impact on Medicaid of the new biennial budget and any new legislation specific to Medicaid's operations?
So our budget was funded, you know, there were a few things that they didn't fund our mobile crisis. But overall, our budget as we currently operate, we can continue to provide services. So we were funded. There were a couple of new requirements that we have to implement. For example, House Bill 6 is non-codified budget instructions. It's nursing home personal needs allowance. House Bill 274, of course, pharmacies can vaccinate children 5 and older now. It used to be 9 and older. Senate Bill 280 was related to new professional services in our hospital reimbursement improvement program. Impacted that. Senate Bill 74, House Bill 10, lactation consultants, opportunity to increase our FPL for pregnant recipients. There were some new restrictions. House Bill 477 limits us on sepsis. You know, we currently hospitals use sepsis 2 criteria. We were trying to move to sepsis 3 criteria, which is what the 47 or 48 other states currently use, but we are limited to sepsis 2 now. We will not be able to move to sepsis 3. House Bill 505 has some provisions related to case managers, peer support specialists, for example. We can't restrict hours for peer support services, and we must allow peer support service specialists to treat groups of 12 and allow temporary license. Senate Bill 71 and Medicaid eligibilities and penalties for individuals who move into the state only for the purpose of receiving treatment. I think this is related to information conversations that we heard that maybe some providers or some individuals were moving into Kentucky just to receive substance use treatment, and then they were moving out, or they were, maybe some providers were actually recruiting individuals to come into the state to provide services to them. And then when those individuals either were finished with services or did not complete their treatment, they were in Kentucky, and some of them were homeless, and then trying to get them back to the state to which they were originally from became somewhat of an issue. So those are some of the major ones that we've been looking at, and that we'll have to do a little bit of work on. Also, House Bill 6 was a study related to 1915C waiting lists.
Yeah, I was going to say there's a lot of interest in that particular one because of the incredible funding for 1,925 new slots, but it comes with a very tight turnaround for you all to report on how those waiting lists will be managed. And I think that report is due maybe in October.
Yeah, it's due really soon.
Yeah. So, excellent rundown. Does anybody have any questions, of the commissioner about the, budget or, legislation? All right, thank you very much, Commissioner. Our next question was, and I think this is an ongoing one, update on unwinding for Medicaid flexibilities and any changes in approach.
And I don't, is, the Senior Deputy Commissioner Veronica Judy Cecil, I know she was in a meeting. If not, I do have a, do have some information that I can pass along.
I do not see her, Commissioner.
Let me see, I do have an update from her. And I do have a presentation, but I don't know if you want to see the presentation. It's the one she typically gives when she updates on the public health emergency. But you know, the main thing I think that I would like to pass along is that all of the flexibilities that we had in place we thought would expire in December of this year, but CMS is allowing us to extend those to June 30th of 2025. So that's some really good news about all of those flexibilities. We're still, you know, there was a report that was created. I can't remember if it was Kaiser or whatever, that showed Kentucky was one of the best states in retaining children in our during our unwinding services. We are getting ready to end. I guess this month will be our last month of unwinding. We have made some enhancements to our system for members to make sure that they maintain eligibility. And again, the whole purpose of you know, unwinding, the one thing that we wanted to do was retain those individuals who qualify for the Medicaid program and help those who did not qualify transition over. So I think we have done a really good job of doing that. So we had anticipated, I think at the beginning of the unwinding period, where we had about 1.7 at the highest during COVID, we had 1.7 million individuals, and we currently have 1.5. So we had anticipated we would lose about maybe 200,000 individuals. So our projections were right on target, and we currently have 1.5 million individuals in the program. We have sent out Medicaid surveys related to unwinding. And so we're gathering that feedback. And again, you know, just stay informed. We are continuing our meetings, or our online meetings that we were having, or informational sessions related to unwinding. We are going to continue those. And I think that what we're going to do is keep those on the books going forward, and maybe start transitioning those informational sessions to be more Medicaid focused and not just unwinding. So happy to answer any questions on the unwinding.
Very good. Any questions from any of the MAC members about unwinding? Do I remember that the children are being looked at starting in September? Is that right?
Yes, but now since the flexibilities have been pushed out to 2025, we're going to see if we can't continue those all of that enrollment until we have to start in 2025.
Oh, okay. Yeah, so important to keep the kids in the house,
Yeah.
so to speak. Any questions for Commissioner Lee on that?
Commissioner Lee, can you kind of explain the difference between flexibilities and Appendix K?
The Appendix K flexibilities are strictly related to the HCBS program. So those E14 or 14E, and we get those confused, are a little bit different. They're more related to the eligibility, but the Appendix K is strictly for HCBS services.
And just to clarify, those flexibilities have come to conclusion, correct?
Yes.
Okay.
And I think Pam Smith is on the line. If she is on, she may
I am, yeah.
can add a little bit more to that if
Yeah,
needed.
so they, the ones that I'll get links, I can put links to the presentations. Though there were some flexibilities that we continued. and made permanent by, modifying the waivers. And so those are in place as of, May 1st for all the waivers except Model 2, which was, February the 1st. But I will get the link to that presentation and the recording of that presentation, that's on the website, that lists all of those. It has the document that lists everything, and where to call with questions.
Does that answer your question, Eric?
Yes, thank you.
Yeah, that would be very helpful, Pam, because I do think that there are still questions about Appendix K. So that would be great to have those links. Thank you. Any other questions on unwinding flexibilities and so forth? Well, good news that that CMS is extending those flexibilities until, what'd you say, July of 2025?
2025.
Yeah, wonderful. We'd like an update on mobile crisis delivery implementations. It's the last report.
So, the legislators did not fund the mobile crisis delivery system that we had designed. Medicaid covers mobile crisis. We have our municipalities that cover, their first responders respond to crisis. So there is a mobile crisis infrastructure in place. It's just somewhat maybe uncoordinated. So our vision was to build a mobile crisis continuum of care that served everyone, including individuals not enrolled in Medicaid. So since it was not funded, we've had to take a step back and make sure that we are continuing our current mobile crisis services that are in place. So just had to take a step back from that right now, and just we do have it on our radar, but not something that we can implement at this time.
So I know that Caroline was given a contract to coordinate all of that, Commissioner, with the RFP that you all put out and so forth. So
Yeah.
are they're still working on this?
Well, we're reevaluating, based on what we can do and the current infrastructure. So we're just really reevaluating that. We had thought that maybe they would serve as the air traffic controller, if you will, for the 911 and 988, but we're just reevaluating right now.
Okay. Because there was, I think lots of, this was a whole new system coming in, and 988 was going to be involved, and obviously 988 is still relatively new. I guess we're coming up second anniversary of it in July. So there's from your perspective, there's just kind of a hold on the new program, the new implementation.
Yes.
Okay. Any other questions from any of the members on that? Thank you. And then we've got a couple of exciting waivers that are out there that we're waiting. I think they're in different stages of approval, hopefully by CMS. So I wonder if we could have an update on the reentry waiver.
So we did have a conversation with CMS. CMS has a backlog of 1115 waivers, which is our reentry is an 1115 waiver. And so what they have done is they have gotten states into cohorts based on various factors. And so Kentucky, really happy to report, is in cohort 1. So we hope to have our reentry waiver approved by July. We are still continuing to work with them on our approval process. So we're hoping that one will be very, very soon. The SUD-SMI anticipated approval by September of 2024, and we'll have more discussions following the anticipated reentry approval.
So that's the 1915I state plan amendment. You think is
no, Well, I'm sorry, the SUD SMI recuperative care pilot is part of, I think, the reentry. So I don't know if Ann or Leslie is on the line, or Angela, that would Angela Sparrow, to kind of provide that 1959.
I can
update.
provide, Commissioner,
Okay,
I can
Pam.
provide it.
Okay.
So we have submitted it to CMS, and we were, actually, they have followed up with one question and have let us know, based on our early conversations with them and the prep that we have, we are skipping the 15-day call, and we are expecting at any point in time the official, the IRAI, which will be just for us to respond to questions. So it is moving through quickly. We're very excited. CMS was excited to receive that waiver. So it is, I'm expecting in the next, within June, to get that request for additional information, the informal request for additional information. So it is moving through the process quickly. They are reviewing it. The one question they had was a simple copy and paste error that was going to be an easy fix. So
And that's the 1115, Pam,
that's the 1915I.
the 1915I is what you're
Uh-huh.
talking.
Yes.
Oh, okay. Oh, wow, that's all right. I was still back on the 1115 that has the respite and extended hospitalizations. And is that the one that's part of the reentry?
No, ma'am. It's its own application.
Okay,
So the SMI that has extended hospitalizations and the recuperative care pilot,
right.
that's in queue. That's the next. They're focused on getting our approval for the reentry, and then our overarching SUD 1115 is also in queue for this September with our SMI that has our SMI 1115 that has the extended hospitalization coverage and the recuperative care pilot.
Okay, because I think I got confused somewhere along the line, Ann, and thought that had been approved already.
No,
Okay.
we've submitted all our applications, and as Commissioner Lee said, CMS has a backlog, and they're trying to, I don't know if they're going to do the SMI 1115 with the cohort, but definitely reentry we're in a cohort. The one other thing I wanted to add is that Kentucky was selected as one of the 5 states to participate in the National Academy for State Health Policy. And with the Health and Reentry Project State Learning Collaborative, it's 18-month collaborative that will kick off in June. And so we have a work group that for reentry, and the commissioners from Department of Corrections, Department of Juvenile Justice, Department for Behavioral Health, Deputy Commissioner Leslie Hoffman, and Behavioral Health Supervisor Angela Sparrow will be the core team that do that collaborative. So it's just going to help with our implementation plan developing once we get approval for our reentry pilot. I mean, a reentry waiver, 1115.
Okay, that's good news. I think I heard someplace that it could take a year after final approval for the reentry to really be up and going.
Yeah, if you remember when we got the original SUD 1115, it was 10 months before they approved our implementation plan, and then it was another 8 months before we got some things off the ground. Because you can't really, you can think about and plan what your changes are going to be, but until you get approval of your implementation plan, you can't really start those changes. So yes, they say, yes, you can be, here's your approval for your application, and then let's see your implementation plan, and they have to approve that. So it's kind of a phase process.
Yeah. It feels like we've been waiting for reentry to hit the ground for
We have
5 years, 6 years.
we were one of the first states to send
Right.
one in, right? In 20, I don't know, I've lost it, maybe 3 years ago. And basically CMS wasn't ready for it. They were trying to catch up. So
Right. And they changed the guidance, and you all had to go back to the drawing boards.
Yeah, you're correct.
And poor Steve Shannon has been chairing the reentry TAC for all that time, getting ready. So Pam, let me go back to the 1959 for a minute. So it's been sent in. You had one question back. And you're expecting an official response in June?
We're expecting to get the IRAI, so that informal request for additional information, we're expecting to get it in June.
And
Like I said,
that's,
the one question they had, it was a copy and paste error that was gonna be an easy fix.
and once that is finished, then we move on to approval by CMS?
Yeah,
Is
so
that
once
the
that,
next-
so what happens is they will send that to us. We will review all of that and provide responses, and then they will complete the waiver. That it stays on the clock the entire time. So we're all still, time is clicking down. So we will respond very quickly to that, and then we'll expect either an approval or additional questions from CMS. But everything, all indications so far look very good. They have not had a lot of questions.
Okay, well, very good news. Thank you very much. Any other questions from any of the other MAC members? These obviously have to do with behavioral health more so than anything else. But if you think about reentry, we have so many Kentuckians who are incarcerated, and a good number of them have a substance use disorder or a behavioral health issue, and to be able to start treatment while they are still incarcerated and then make that smooth transition into the community is going to be huge. I think it's going to be one of the most impactful things that we've done in a long time. This next, I think, probably is for you, Pam. These questions came from Eric about legally responsible individuals, LRIs, and the Medicaid waivers.
Yes, so so Dr. Wright, I'll go through the questions real quick, and then if you have additional questions, if that's okay, to do it that way. So we delayed the implementation to start the review process until July 1st, and that is because we have actually added it into the system. So it's going to be in MWMA, so there's not going to be any more paper process, any forms. The case manager that is helping with if you choose to participant director services will work with you to directly put that information into the system. So it'll make for easier tracking, and also for in the future, individuals that have already been approved, they will not have to go through any reapproval process, because we won't have to look for paper documents. We will have the actual review in the system. Case managers and support brokers will have information to share. We're actually very quickly updating guides and reference sheets, as well as a very extensive frequently asked questions list. We were working on it this morning right before this meeting. And then I am going to, in the chat, we actually have on June the 10th, we have two sessions. We have a provider. If I can get my computer to cooperate, sorry. We have in the morning on June the 10th at 11 Eastern, we have a provider training. At 3 o'clock that same day, we have a participant information session. And then on June the 20th, we're actually going to have 2 Q&A sessions. One at 2:30 Eastern for providers, and one at 6:30 Eastern for participants. All of these will be recorded and will be available on the website, but I will copy and paste these links in the chat as well. A communication went out, I believe, on Monday that had the information on how to register for those and how to attend those. And I'm not sure if that, yeah, I think that pasted all of that. So you should be able to follow those links. If not, if you reach out to the help desk, the number in the email I put in the chat earlier, they can help with getting individuals linked up to the right meeting.
May I ask a couple quick questions?
Absolutely.
On that notice that came out recently too, it indicated that there is some prior reviews that have been done if you were approved before March 2020. I noticed that it mentions specifically hired HCB or SEL. When you say HCB there, are you including the Michelle P waiver as
No,
well?
that's only the home and community-based waiver, because the only two waivers that required approval of LRI as employees or family members as employees were the HCB waiver itself and the SCL waiver. I know it is so confusing since the group of them are home and community-based waivers, but someone a long time ago thought, that would be a good name for a waiver too. So I know it gets confusing, but it was specifically referring to the home and community-based waiver.
So can you clarify how Michelle P waiver plays into this role? Is it now under the LRI
Yes,
review
every
process?
single waiver that
Okay.
has participant directed services as an option, if the individual is an LRI, they are required to go through that formal review process. And that is part of our attestations to CMS as to how that allows us to be able to pay LRIs for providing these services to individuals.
And when you say formal review, can you give a little more detail on, like you said, case managers and support brokers? Are they going to be the
No,
the providing the guidance, or where does that come from?
they will be providing the guidance. We will actually be providing, so we are doing the Q&A sessions and those informational sessions. And we will be putting out the direction as far as the policy and answering all of those questions. The case managers, and we're actually going to get away from the term support broker, and we're moving to case managers just across the board. But they will be the ones that will answer questions, that will help fill out that will help request the information. The new criteria is much simpler than what it was before. For individuals under the age of 18, it is the individuals that have to be reviewed are parents, and that includes step parents, foster parents, or adoptive parents, and anyone that is a court-appointed legal guardian. So grandparents do not have to be reviewed, siblings. So it's a much smaller group than in the past that had to be reviewed, and they have to meet two sets of criteria. So one is there's three, and I do not have it sitting right here in front of me, but one of them is they have to show that they have extraordinary care need, which most of these children, they meet institutional level of care, so they have extraordinary care needs. They can have a communication deficit that would prevent them from being able to communicate their needs effectively. They can qualify if they have a behavior problem where they may have self-injurious behavior, or they may have behaviors that someone would need to be knowledgeable and know how to manage, that it would be a legally responsible individual that may be best suited to do that. The second portion is that they have to demonstrate that they have not been able to find another caregiver, which that is, we know we do not have very many providers in Kentucky that accept pediatric patients or specialize in pediatric patients, or they have to demonstrate that they have not been able to work due to frequent appointments or frequent calls. And so that is not in any specific period of time. I think it says 12 months or within the last 12 months or longer. So we did not want to exclude individuals that maybe had not been working for more than the last year because they've needed to stay home because they were the best caregiver for their child. For adults, it is the two individuals that have to be reviewed are if you are a spouse or if you are a court-appointed legal guardian.
Pam, I should have asked you to back up, and for those of on the MAC who are not familiar with these waivers, can you define LRI? You've
So
talked about as
legally
responsible.
Legally responsible individual. So for a child, it is any parent, and that includes adoptive, foster, and step parent. And then any court-appointed legal guardian. For an adult, so anybody 18 and over, so it's for child, it's under 18, 18 and over, it is a spouse or a court-appointed legal guardian.
Can I ask a question? What about a parent of an adult child who's not a court-appointed legal guardian?
They would not have to go through the process because it is not expected that a parent would still be providing those types of supports to an adult child. So they do not have to go through that process.
They don't have, okay.
They
I
do
think
not
that's-
have to.
They don't have to,
They do
okay,
not have to. No, it's only, parent is only for those individuals that are under the age of 18.
18,
Mm-hmm.
gotcha. All right. All right, you've
That
cleared
is
up
a
a
little
lot.
different than what it
Yeah.
was. We've narrowed the definition a lot for what the LRI is. And you know, we've been reviewing the individuals that are providing care right now. I've talked to several parents myself, looked at the cases with them, and been able to, you know, hopefully alleviate some of the concern that they had or the fears that they had. We're not anticipating that we're going to just come in and deny a bunch of parents. That's not what we believe is going to happen. But in order to be able to offer this option, we have to fulfill that guarantee to CMS, which is that we have these guards
Criteria.
in place. Yes.
Yeah, all right. You've answered a lot of my questions, and the document actually did as well the other day, so thank you, Pam, for all your
Okay.
help. Appreciate it.
Yeah, thank you, Pam. I think once people can get their hands on the information, my impression from what Eric had said originally, maybe at the last MAC meeting, was that all of this was blowing up on social media as the word kind of spread from maybe caseworkers mentioning it and then parents not knowing where to get the information. So
We do have a lot of helpful people on social media that like to share information, and I like to always just repeat back, please direct people to us and to the different, you know, to Dale or to BDID, and that, you know, as the source of the information. And that hopefully when we do these sessions in June, we didn't want to do them too early. Because since it's not starting till July 1st, we didn't want to do them earlier because we wanted the information to be more fresh. And we're still also trying to work on updating all of those resource guides as well. So.
okay, thank you very much. Any other questions from any of the other MAC members? Thank you, Pam. Erin, do we have a quorum now? We could go back and approve the minutes.
As soon as Dr. Gupta returns from her.
Oh, yeah, she had to be gone for a couple of minutes.
I was
So,
hoping to catch it before she left, but we were in the middle of something. I didn't want to interrupt. So I will remind you before we adjourn.
okay, thank you very much. So let's move on to the TAC reports. Let us know about your meetings. If you've had any requests for information from DMS or the MCOs, whether you're working on anything with perhaps another TAC, and then if you have any recommendations. And we'll start at the back end of the alphabet with the therapy services. And I think that's Dale, isn't it? Anybody on from the therapy TAC? All right, primary care.
Good morning, this is Stephanie Moore. I am the chair of the primary care TAC. We have not met since the last meeting, so there's no report today.
Okay, thank you. Physician services. Is that usually Ashima Gupta?
It is. I was looking to see if Cody Hunt was on. They met on Friday. I can tell you that. That was their first meeting of the year. But I
Okay,
don't see Cody on either.
all right. Well, let's we'll ask Ashima when she gets back. Thank you. This is graduation time, as you know, and I think her kids were having their award ceremony, so she needed to go to that. Pharmacy.
Yes, I'm actually reporting for their February 13th meeting. I apologize that Ron could not be here today. They did cancel their last meeting, but I'm reporting for this former one because they didn't have a report at that time. At this meeting, they continue their discussion on community health worker services. And, just talked about the benefits that could come from pharmacies being able to provide these services with the community health worker pharmacy staff that they may have in place, mainly because it can create a lot of access for these much needed services into our communities. And they continue to ask the Department of Medicaid Services, are they going to plan to add pharmacies to the list of providers who can order and or provide these services? And if not, could the Department of Medicaid Services, provide guidance on statutory, language that need to be changed to allow this to happen? Mainly to benefit our patients and our services because of the access that we could, and the impact that we could have in that area. Also, let's see, they continue their discussion on rebilling of the NADAC. That's where the price, we have a price increase that goes into effect. Takes a while for those to get, show up on the other end. But in the meantime, the pharmacy is paying more for the product. So just in a nutshell, they're having a lot of challenges going to go back and look for these claims because it's like finding a needle in a haystack in many situations because of the complexity of the report. And so they continue to ask if there's some way to get some type of interface to make it easier for pharmacies to search for these claims so that they're not being reimbursed, underwater on those claims, if you will, below their cost. So that's causing some challenges in our communities. As we all know, this is, if those who listen to this, a lot of pharmacies closing in some communities and feel like, it could really help. But the complexity evidently of these reports is hard for pharmacies to go back and look for these claims to try to go back and rebuild them appropriately. The two things, that was an ongoing discussion point. The two newer items that they did discuss was the GoodRx Caremark, goings on. So it appears that sometimes GoodRx is kicking in for these Medicaids. These are on our dual eligibles, just to make that clear. These may be kicking in. They could be dual eligibles, or they could be individuals who have, commercial insurance, and then Medicaid pays on the back end. And so what's happening is these are coming in with GoodRx with a higher copay than you might see normally for that patient under, another plan or Medicaid, or, typically. And so therefore Medicaid is picking up this portion of it, but it does lead to Medicaid paying more. And the pharmacies then being charged a fee back on those claims. And so it negatively impacts both Medicaid and the pharmacies in many situations. Okay. And then they also did discuss Anthem dual eligibles. And this is primarily, I believe, I will try to get clarification for the next meeting on their DME products, such as their test strips and stuff that are coming back with a copay, due to a deductible. I guess it's not really a copay, it's a payment of a deductible. And then when the pharmacies were trying to bill this to Medicaid, the claims are getting denied. Probably, I think I did talk to Timmy about this at one time, but it's been some time ago because of processing issues between the DME coming over to the pharmacy side, and also because these products may be, from what I remember, non-formulary products under Medicaid. So that continued to be an issue that they did discuss. They did not have any recommendations at this time, and their next meeting, I believe, is on June the 5th. And I thank you.
Thank you very much, Kathy. So are they meeting with Medicaid during their TAC meetings? Do they have
Yes,
Medicaid staff?
I do believe that Fatima is usually, or a representative from Medicaid is on the call whenever they are meeting.
Okay.
That's been my experience.
Okay. Because I'm just wondering on some of these, if more dialogue directly with Medicaid about resolution of the GoodRx, for instance, and also the Anthem issue, those new items.
Yeah, I
Dr.
think the
Schuster
bigger
and
ones-
Kathy, this is Leon Lamoureux. We did become aware that the Medicare health plan did implement a DME deductible as part of the new benefit design. And we've worked with them for at least the DME or the test strips for diabetes. They will no longer be subject to the deductible. Other disposable medical equipment will still be, but we addressed that very, very quickly as soon as we became aware of it, so that we've been able to address that concern,
Thank you.
at least for the
That's-
DME test strips.
Okay, good. And like I said, that might have been an old thing on there that had come up at that meeting, but yes, thank you for that. I appreciate it.
Yeah, we certainly want to have our diabetic members
Mhm.
have those test strips without any problem or without anybody having to pay extra. Thank you, Leon. All right, thank you very much, Kathy. Appreciate it. Steve Shannon, persons returning to society from incarceration.
Yeah, thank you. This is again Steve Shannon. I'm chair of that TAC. Our last meeting on May 9th, we had a great PowerPoint presentation about the waiver and the status and benefits and what it looks like. We meet for about an hour plus, and that was all we talked about at that meeting. I would encourage Dr. Schuster that perhaps an abbreviated version of that be shared with the MAC at an upcoming meeting to really understand. We heard some of it from Commissioner Lee today and Ms. Holland, but Angela Sparrow just did a great job, Medicaid staff person, behavioral health lead, on laying out what it looks like, what's going to take place. And that's really all we did at our past meeting. No recommendations, but it was a great educational opportunity for all folks who participated, who joined that meeting. I just think it'd be valuable for the MAC to see that. It's a great way to lay it out and understand it. We are looking forward. There's an advisory committee that's been formed that will help guide and shape this implementation. And so we're excited about that as well. And I think we'll all be part of that or have an opportunity for input. It was just great to see it laid out before us for the first time in over 2 years. We've been talking about it kind of philosophically. Now we had something on paper we could see and understand and grasp and move forward. So that's my report, but I think it'd be beneficial for the whole MAC to see that information.
Okay, thank you for that suggestion, Steve. We've certainly talked about it. And since we're getting close to, maybe we'll celebrate CMS approval by having the presentation at the MAC after that. So I do think it's going to affect a large number of Kentuckians.
Correct.
And really move people into recovery, we hope. So thank you for that. Optometric care.
Yes, Steve Compton of the Optometric TAC. We actually canceled our April meeting, so we have no report, and we meet again in August.
All right. Thank you, Steve.
Thank you.
Nursing services.
I believe Lisa had a conflict and was not going to be able to be here today. She had patients, but they did recently have a meeting last week. No recommendations that I recall.
Okay. Thank you, Erin. Nursing homes.
They have canceled their meeting for next week. Terry said they had no agenda topics at this time.
Wow. Does that mean everything is going 100% for nursing home? I'm sorry. It's hard to imagine that there aren't some issues.
From
Thank
my
you.
understanding, they've been working with some DMS staff on some more provider specific issues versus like TAC issues.
Okay. All right. I see Rick Crispin for the IDD TAC.
Yes, we met on April 2nd. We had a quorum. Among the items we discussed, again, were involuntary terminations, particularly from the SEL program, which is residential services. And for example, as of that date, 65 people had been involuntarily terminated in the past 6 months. We've decided to gather more information, seeing, for example, what the crisis units might do, mobile crisis units. Beyond that, we talked about, tried to get some more information about the revised rates and regulations, but we were asked a little bit early on that, so maybe our next meeting we can get into that in more depth. Beyond that, we had no recommendations, and that's my report.
Okay, thank you very much, Rick. Hospital care?
This is Russ Ronaldo reporting for the hospital care. We had a meeting on April 23rd. We had a quorum. We had no recommendations. We discussed several topics. Just to highlight two of those out of the report. One, we've had several issues on incarceration. The DMS worked with us to set up a meeting with the Department of Corrections and folks from DMS, and we went through multiple questions and concerns and made some good headway, and we'll continue on there, and we're appreciative of those efforts and DMS helping with that. And then looking at we've got an issue with denials in the emergency room where we have several MCOs that are using a software and an algorithm to downgrade ED visits and reduce payments. But we're not seeing reasons why, and there's a lot of lack of understanding about how the algorithm and the software works. And so we're diving into this, but I expect that it's going to become a more heavy issue as we dive in. But that's all I have right now. Thank you.
Russ, you mentioned an incarceration issue. Can you explain a little bit?
So we've got multiple about it's a whole host. There's probably about a dozen, and it's about who's ultimately responsible for the bill on different situations. There are a lot of situations where we have somebody's presented to the hospital and they've been released, but the website's not updated, and so then the claim gets denied. There's been cases where people are brought in and they're either in custody or not in custody, and who's responsible for that bill. There's a lot of not consistent process being applied across the regions, and what we were trying to get was some clarification on, who's ultimately responsible for the bill, how do we get it streamlined, and I think the take home from the meeting was we really need to have continued education, but maybe an FAQ that's worked up that everybody can point to and follow. It was very productive discussion. I was very pleased and very appreciative of everybody that was on the call. But it's a lot of just individual examples of cases where the hospitals feel like they're in the middle. And both sides are telling us they're not responsible for the bill, whether it's the jail or the MCO, and we're just trying to get clarification on who's responsible so that we can have our processes correct.
Good, thank you very much. I was curious about, and I can see where you all get caught because you have to treat whoever comes in the door, and so you have, and then you're looking for, as you say, who's the responsible person. Thank you for sharing that, Russ.
Yes, thank you.
Home health.
Hi, everyone. Evan Reinhardt from the Kentucky Home Care Association reporting for the Home Health TAC. We met on April 9th and discussed some guidance and reimbursement for supplies, as well as coding, and also requested each MCO to supply their type of bill requirements. And then we received some electronic visit verification updates, and we did not have any recommendations.
Okay, thank you, Evan. Health disparities. Anybody on for health disparities?
I do not see anyone. They did move to quarterly. I do not believe they've had a meeting since the last MAC.
Okay. Thank you, Erin. EMS.
I believe it's the same with EMS.
Okay. Dental.
Yes, this is Dr. Bobrowski. We did meet a couple weeks ago, and we did have a quorum. We are working with Commissioner Lee and DMS on some data issues. The Kentucky Dental Association and myself and Commissioner Lee met with representatives of the Primary Care Association, and we're kind of some preliminary talks about dental care, dental access. So that's going to be an ongoing meeting. It kind of ties in with the TAC, but we did meet with the Primary Care Association, and we've been working with Commissioner Lee to make some certain items of care just easier to do. And I want to do a public apology to Commissioner Lee and Justin Derringer, some of the other, Aaron, and some of the other members of the DMS that on the last TAC meeting, I put something on the agenda and I was complaining, well, we got to do this to get this done. You know how some things have to go in sequence. Well, I don't get on the website every day. So, and before I got on these committees, I probably didn't get on them once a quarter, once a year. But anyway, I do want to apologize to them that they had fixed the issue probably 2 or 3 months before I even knew about it. So it is a heartfelt apology to you all. And at this time, there's no recommendations to the MAC from the dental. Thank you.
Okay, thank you very much, Garth. Consumer rights and client needs.
Good morning, everyone. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health, and I chair the Consumer TAC. Before I talk about our last meeting and give our report, I just wanted to really follow up on what the hospital TAC was discussing at their last meeting related to people who are incarcerated and are released and then have a suspension on their coverage and aren't able to use their Medicaid coverage because of that suspension not being lifted. That's been an issue for many, many years now. And I do think that the reentry waiver, when it's approved and of course implemented, could greatly help in that situation because people should be getting enrolled and have their coverage activated before they're released, at least if they're in prison. That won't be happening in jails. But something else that I think we could be doing, and I would love to see some efforts made toward doing this, is to look at just not having a suspension at all. We had talked a few years ago to Vicki Wachino, who used to be one of the top administrators at CMS and has since started the Health and Reentry Project. I had to look that up to remind myself exactly what it was called. But she has really focused a lot of her efforts since leaving CMS on healthy reentry. And we had, essentially sought her advice on what we could do here in Kentucky. And, while the suspension ensures that there aren't services being paid for by Medicaid while someone is actively incarcerated, I think there are other ways that we could ensure that whenever people are incarcerated and then upon release, there would be just no suspension to have to worry about. I think putting it on the jails, the prisons, and of course providers to make sure that they're not billing when someone is incarcerated is really the better solution there. And, clawing back anything that does maybe unintentionally or intentionally get billed during incarceration would be better than having that suspension in place. So I'm just going to put that out there. It's something that we raised a few years ago, and I think maybe should be revisited. For our consumer TAC, we met on April 16th. We met remotely using Zoom. We didn't have a quorum, which is pretty unusual for us, but we had some people out sick. We did discuss a number of our usual topics. We discussed Medicaid renewals, network adequacy, and some quality initiatives that CMS or DMS is actively kind of putting in place related to health-related social needs, which is a new term that CMS is using for things like access to safe housing and nutritious food. We more commonly refer to that as, social determinants of health, but they're very interrelated. So after a full year of processing Medicaid renewals for adults, and I know that Commissioner Lee gave us a great update just earlier in the meeting, I just wanted to touch on a few things related to what we've learned. Of course, it's been a challenging process. We've seen a number of Kentuckians lose their Medicaid coverage, hopefully because they were no longer eligible and not for administrative reasons, but we know that some of them were for administrative reasons, too many. But we've learned a lot of lessons. And what I want to say is that we really appreciate how much DMS has worked with connectors and advocates to identify and fix system issues that have probably been there for a long time. And we just didn't realize how common they were, how much they were sort of contributing to churn and to administrative either denials or discontinuances. And so I think the process that we've gone through has actually improved our system in a number of ways. And with child renewals, in our future, whether that's September or maybe even a little further down the road now, I think that we're going to be in a much better position to do those renewals and have fewer children losing coverage because of the system fixes that have been made. Two in particular that have stood out to us and that are pretty recent are one that led people to lose Medicaid coverage after they lost SSI without first being considered for another type of eligibility. And those individuals should now be receiving pre-populated packets and should have that opportunity to renew their coverage before they lose it and have to reapply. So that is a big improvement. And I wonder if that gets to some of what we heard earlier about people, the IDD tax saying that some people had been terminated. And then the other big issue that we have identified that's been fixed or is being fixed is about 29,000, it impacted about 29,000 Kentuckians who have had their coverage reinstated, essentially because information that DMS had available through different data sources was used to determine that they weren't eligible, but that was passively determined. That individual didn't receive a request for information, that an RFI, to ask them to verify that the information was correct and up to date. So that is a situation that I think is in our past and should no longer be affecting Kentuckians moving forward. And that really is a big improvement. So we know that letters have been going out to these individuals. I assume that not everyone will be aware that their coverage was reinstated. And so it's important for connectors and providers to notify patients who were affected. But again, I just think we're in a much better position now to start child renewals whenever that does start. And of course, having coverage alone doesn't mean that people who are getting needed care are getting the care that they need. So that's why we at the Consumer TAC, we've focused so intently on network adequacy over the past year. At our last meeting, we reviewed a second draft of the form that they're calling Access to Services. This is something that DMS has been developing with our input. And this is going to be a really helpful tool for DMS to identify Kentuckians that aren't able to access a provider in their MCO network, in their region where they live, and to be able to really better understand where the gaps are in our network so that we can start to focus more systemically on that, making improvements. And we also learned at that meeting in April that DMS should be getting their first report from the MCOs in May, so may already have gotten it, regarding providers who haven't billed a claim in over a year to determine if they're actually serving Medicaid members or not. So the issue now is that, you know, if you're an enrolled Medicaid provider, you get counted as active and available even if you're not seeing any patients or maybe seeing just a few patients. And so, of course, that creates a type of shadow network, if you think about it, where we have providers, but they're not actually accessible. So to have a more accurate and meaningful network, we really need to make sure that we're basing that network on the volume of services being provided in a particular geographic area, so that we know that people are actually able to get those services and in a timely manner. And then in our past meetings, we've explored new opportunities provided by CMS to redirect some Medicaid funds to cover health-related social needs, which, like I mentioned, housing and food. Of course, we've been talking about that a lot with the SMI waiver, Sheila, and you know, really looking at how we can provide more of those wraparound supports to certain individuals who are high risk and experiencing different health disparities. I think it could go a long way in helping to reduce those health disparities and manage chronic conditions like asthma and diabetes, but also severe mental illness. We've been learning a lot about initiatives that the state is implementing to start screening for and tracking social determinants of health through hospitals, MCOs, and even now the Medicaid application. And so I think that's going to be, again, another good tool for us to understand where some of those gaps are, where people have basic needs that aren't being met. And hopefully we can then put together a really strong proposal to CMS to say, hey, this is how we need to be spending our Medicaid money so that we can be addressing some of these health-related social needs. But back to this screening for social determinants of health, and of course, there's Connect Resources, which is a referral system where you can actually make referrals to the different community providers. That's something that we discussed as well. And while we think that there's a lot of opportunity here, of course, there's a lot of need in the community and with Medicaid members in particular. But we know that CBOs, community-based organizations, are often overwhelmed by the volume of referrals. And some of them have been concerned about sensitive information, how it's being handled, particularly for individuals experiencing interpersonal violence. And so that's something that we really need to put more attention and just thought toward as we're developing this and continuing to make improvements to the system. Following our last consumer TAC meeting, we did have the opportunity to discuss some of those concerns with cabinet staff in more depth, and they've agreed to meet with CBOs in June to hear how referrals are working and also consider what changes could be made to address some of those concerns. So that was a positive outcome of our last meeting. And while we didn't have that quorum, we weren't able to make recommendations at our April meeting. I did want to express appreciation for DMS, their most recent responses to the recommendations that we made at the MAC meeting in March. Those were regarding input on the Medicaid membership survey and accessibility through the use of video explainers, screen readers, closed captioning, subtitles, those sorts of things that improve accessibility for folks. In both of those cases, DMS expressed that they already had plans in place, and they provided a timeline for completion within the next few months. And so we were really pleased to hear that. We were able to give some input onto that Medicaid survey before it went out, and that was also a really good opportunity. So we're looking forward to seeing what the results are once that survey closes and DMS puts together a report. That's it for me. I'm happy to answer any questions if you have any. Our next meeting is scheduled for June 18th at 1:30.
Thank you, Emily, and thanks for kind of pulling in the incarceration issue. I think one of the providers, Beth, put in the chat that a lot of times providers don't know if someone was recently incarcerated and may be in that suspension mode. And I do think that there's some issues there as well, but appreciate your report. Children's Health TAC. Have they met? Do you know, Erin?
They met in April. I do not see anyone on, and I do not believe they had any recommendations.
Yeah, I don't think we've had an actual report from the Children's Health TAC, and it feels like many meetings. I'd have to go back and look, but it would be nice to hear what they're discussing. Thank you. The Behavioral Health TAC met on May 1st. We welcomed a new member, Tara Hyde, representing PAR, and we had a quorum. We had anticipated that we would get a report from the Office of Data Analytics about multi-state comparison study of rates, but that's been delayed till the July meeting. We had an excellent presentation by Jennifer Dudzinski about audits being conducted by the MCOs, both prepayment and post-payment audits, and got a much better understanding of how that all works and the role of DMS in that. We had forwarded 11 questions prior to the meeting, and then Jennifer made an excellent PowerPoint available, and we're going to have a recommendation here in a minute about that. We got waiver updates, and I won't go through that because we heard a lot of that. The discussion around behavioral health associates, that's a kind of reformulation of people that have a bachelor's degree and are working on a master's in a profession and what their role is going to be. And Jonathan Scott has been working on those regs. And I believe that they were not presented in May, but are being presented to the Administrative Reg Review Subcommittee in June. Justin Derringer gave us a good report on no-shows. You might find this interesting, Garth, because the no-shows come up frequently from your perspective with dentists. 89,941, so about 90,000 no-shows were reported in 2023. And of those, 64,000 or 72% had no reason stated. So not very helpful in terms of trying to address some of those social determinants of health and figure out why people are not keeping their appointments. Interestingly, the highest number of no-shows reported by provider type were from the occupational therapists. And the area of the state with the highest number of no-shows was Louisville Metro. Justin indicated that CHWs could possibly be of help in contacting individuals to get a better idea of the reason for their not keeping their appointment, which I think could really be helpful information. And he emphasized, and I think we've emphasized it here at the MAC, but it bears emphasizing again, the importance of more providers using that portal and reporting their no-shows. So that's something, and Garth, I'm not picking on you, but you know, you've brought this up many times. And so the next time your dental TAC meets or you have meetings with your dental colleagues, I would sure encourage them to make those reports. I'm not sure that we have a good representation of behavioral health clients that are not keeping their appointments either. So we will bring that up again at the BHTAC. Under new business, we have an MCO that sent a letter to several providers and made a blanket statement that they were reducing reimbursements by 20%, which has caused a great deal of consternation, as one might imagine. So Leslie Hoffman and Angie Parker pointed out that MCOs are required to give 30 days notice in such cases. Providers can examine their contracts with the MCO to see if that is addressed or not. Those can be negotiated, and providers do not necessarily have to accept that cut and pay. They may decide not to be a provider with that MCO any longer. It was pointed out by one of the attendees that if a number of providers do that, we could end up with a lack of access to behavioral health services, since that MCO has a large number of Medicaid members. Our recommendation is that Kentucky Medicaid provide written guidance to providers about the pre and post payment audit procedures and how each MCO is implementing those procedures. And I will send you that in writing, Erin, so that you have it for your records.
Thank you.
Yes, so that was our recommendation. The TAC will next meet on Wednesday, July 11th, and that was our meeting. Is Ashima back?
Not
Erin?
yet.
Not yet. Okay, so we don't have physician TAC. So we don't have a quorum still, right?
No, ma'am. Sorry, I was trying to read the chat really quick as well.
So we can't make a motion to accept the TAC recommendations. I think it was just that one from the BH TAC. Do I remember that correctly, Erin? I don't think any of the other TACs.
And no, we only had the one recommendation this time. If you'd like to discuss your next 7 and 8, and as soon as she hops back on, I can let you know.
Okay, thank you. So Eric Wright brought up initially the issue about people having so much trouble figuring out how to access Medicaid, and then particularly the Medicaid waivers. And we discussed that at the last meeting of the MAC, and Pam Smith said that she had a number of documents that were available on the website and so forth. Pam sent me those documents. I've since also talked with a couple of individuals who had reached out to Commissioner Lee with specific issues, both of them about children with significant healthcare and behavioral health needs, and have actually heard from a number of other consumers and family members about this issue. So I took those documents that Pam sent, which were a variety of probably 5 or 6 different documents that discussed how to get into Medicaid, but more specifically discussed information about the waiver. And I sent that information to a number of our TACs and asked for their input. So I think I sent it to the Children's Health TAC, the Consumer Rights TAC, Health Disparities TAC, the IDD TAC, and that may have been all, but I'm happy if any of the other members of the MAC would like to see that material. What we're trying to do is to get lots of input about, the Consumer TAC will discuss it at their next meeting. What are your recommendations, not only about the documents themselves, but one of the things that came up as Pam was telling us about this information, if people have no clue about how to access Medicaid, then documents that are on the Medicaid website may not be readily available to them. And we know, I did send that information also to some of the consumer and advocacy groups around disabilities and behavioral health to ask for their input, because I think the more we have boots on the ground, let's call them, the advocacy groups like the ARC or the Commonwealth Council on Developmental Disabilities or the NAMI groups, with this kind of information, the more likely that our family members and consumers are going to be able to access it. So we're looking here at both the documents themselves and what kind of information is needed, and then what the process might be. Pam also said that internally she has some work groups working on that. So I guess I would just like to keep this on the agenda. I do think that the MAC can play a very helpful role with all the different perspectives that are represented on the MAC. and giving some recommendations about how to simplify this information and how to simplify access both to Medicaid and to the Medicaid waivers. So I just wanted to give you all that update. And again, if there are any questions, several of the tax, we're going to talk about it in the upcoming months. So we'll look at this again in July. And we'll also ask Pam to report on how her internal work groups are operating. But if any of you would like for your TAC to receive this information and give us some input on it, I'm happy to forward that information to you. And I would ask at this point, is there any new business that anyone on the MAC would like to bring forward? But, excuse me, I'm kind of froggy this morning. No new business. Okay. So we have several ongoing kind of big picture things. I think this CMS requirement by July of 2025 to have in place a BAC, beneficiary advisory council, is going to be a big lift, and making whatever changes we need to make in statute around the MAC and the tax. One thing I would ask of the MAC members who also are representing groups that have tax or attend those TAC meetings is to take back that question to the TAC, to look at your statutory reference in terms of who nominates members, for instance, for your TAC, and to, because if there's going to be any changes made in that, this is the time to do it. We're going to have to start working on that legislation very soon. They will go back in session with a number of, I guess, already elected new members on the first Tuesday after the first Monday in January. And then this is a 30-day session. So they'll meet that first week in January, and then they'll go home for about a month. But then when they come back, it's, you know, hellfire to get something passed because there's so much going on in a very, very short time. So just to alert you. And our next meeting is Thursday, July 25th at 9:30.
Dr. Schuster, we still don't have a quorum, but you don't need a quorum to vote on your recommendations, just your minutes.
Oh,
so we
okay.
can move the recommendations forward if you want.
Yes,
we can give
I
it
would.
another moment if you'd like to wait. It's up to you.
Well, let's go on. I didn't realize that. Thank you, Aaron. The motion made by the Behavioral Health TAC is the only one that was put forward. So I would entertain a motion to accept that TAC recommendation and send it on to DMS.
So moved.
Thank you, Garth. Is there a second?
Second.
I'm sorry.
Second, I think there were two of us, so it doesn't matter.
All right, Kathy, thank you. All those in favor of forwarding the BH TAC recommendation to DMS signify by saying aye.
Aye.
And anyone opposed? And any abstentions? Thank you very much. And I appreciate that, Aaron. I assume that we needed to have a quorum. Someone from Kentucky Medicaid says I cannot hear anything. Did you see that, Aaron, in the chat?
That may be Aaron. I think that's either her or maybe Kelly.
Oh,
So should I just tell her you just made a motion to?
yes, that we made a motion to move the BH TAC recommendation on to DMS. Did any of you all have trouble signing in this morning on the Zoom?
I did not.
Okay.
No, I didn't
Well,
either.
Maybe it was just me. I got nervous Because the last time we had a BH TAC, a few minutes before. Peggy, did you have problems?
Yes, I did.
Okay, I wonder,
I did as well. It took a long time and just kind of spun on the clock for quite a while. And then it finally popped up for me, but I had a little trouble as well. So
okay, Aaron and Kelly have had to ride herd on that. And we had, a terrible period of time there where all of a sudden the Zoom links weren't working for the tax and the Mac and so forth. So I'll pass that along to them when they, outside of the meeting. I think we'll go on and adjourn. I know that Ashima was going to try to get back, but I also know how school award ceremonies go, and they're very unpredictable in length. You want to be there for your kids, but so we'll approve the minutes at our July meeting, and we will adjourn by acclamation. So if no one has any objections, we'll give you back quite a bit of time on your morning, early afternoon. I wish you all a happy long weekend, and let's remember those who have given their lives so that we have the freedoms that we have, and we really need to cherish those freedoms and cherish those who gave the ultimate sacrifice to get that. So thank you all very much, and have a great long weekend, and I appreciate your service to the MAC.
Thank you so much, Dr. Schuster.
Thank you.
Dr. Schuster.
Thank you.
Bye-bye.
Bye-bye.
You.